for joining us for our bi-monthly symposium series. Today we have Dr. Mehrara, who's sitting here with me, who's going to be giving a symposium on preventing lymphedema, separating fact and fiction. Before I introduce Dr. Mehrara, just a few comments and updates from the LRF. First, I really would like to mention the unsung heroes. Dr. Phyllis Freed, who is our medical coordinator and medical director. Dan Trachtenberg, who's our operation director. Colleen McGuire, who's our outreach director. And Laura, who is our communication director. Really want to thank them all for putting this together. Without them, we wouldn't be able to have these symposiums. So first of all, thanks to them. And also I want to thank our friends at the National Lymphedema Network and also the American Lymphedema Framework Project and the Lymphedema Treatment Act, all of which who have spread word about these symposiums on their websites. We're one community, we have one goal in mind, and their support is greatly appreciated, so thanks. Also, I wanted to say you can mark your calendars for our next symposium on Wednesday, September 25th. The time still to be announced. Dr. Stanley Roxon will be speaking at that time. Dr. Roxon is the director of the Center for Lymphatic and Venous Disorders at Stanford University School of Medicine. And his topic will be lymphedema, where have we been and where are we going? We are also working on a special symposium for October where the topic will be lymphatic malformations. So stay tuned for more information about that. If you are on the LRF mailing list, you do know we're in the midst of a mid-year appeal. For all of those that have contributed, thank you very much. For all those that plan to contribute, thank you. We just have authorized our next series of research grants, and it's your funding that allows this research to actually occur. So thank you for that. And lastly, we will be having our national walk on September 8th at Eisenhower Park on Long Island. So that will be live streamed, so people all around the United States can participate. And we look forward to you thinking of ways to actually have events in your own home community at the same time that coincide with the walk to truly make it a national event. With that, back to the reason of why we're here today, and that is Dr. Mehrara's symposium, Preventing Lymphedema, Separating Fact and Fiction. First, an introduction, which is well-deserved, so I'll read it. Because, as you might suspect, Dr. Mehrara has a lot of credentials. Dr. Mehrara has published over 140 peer-reviewed articles. He serves on the editorial board of the Annals of Plastic Surgery, and he conducts basic and clinical research, including research into lymphatic tissue engineering. He is a board-certified plastic surgeon who specializes in surgical reconstruction after cancer surgery and is supported by several private foundations and federal government grants. Dr. Mehrara earned his medical degree from Columbia University's College of Physicians and Surgeons. He completed his residency and a fellowship at New York University Medical Center, as well as a microsurgery fellowship at UCLA Medical Center. Dr. Mehrara has a strong interest and expertise in post-cancer treatment and secondary lymphedema. Most of all, Dr. Mehrara is a great friend to LRF. He has done symposiums for us before, and if it wasn't for Hurricane Sandy, he would have been doing this symposium back in last October. But at that point, it would not have been live streamed. So for those of you around the country that are watching this, technology caught up with us, and as a result, more of you are going to have an opportunity. I would say also remember, you can ask questions by typing them in online in real time, and Dr. Mehrara will get to as many as he can during the symposium, and others as he's available he can respond to afterwards. So with that, thank you very much, and I turn it over to Dr. Mehrara. Thank you.
Great. Thank you for that really fantastic introduction. And today I wanted to talk a little bit about some of the things that are sort of told to patients with lymphedema, or those patients who are at risk for lymphedema. And I think this topic came along a few years ago when we were in the operating room, and we were looking for over an hour trying to find veins for someone to have an intravenous access, an IV catheter placed, and we really couldn't find anything. And there were beautiful veins on their arm that had actually lymph node dissection, but we were avoiding them. So we wanted to go back and see how much of what is told to patients who have lymphedema or patients who have actually lymph node dissection is really based on fact and what part of it is really based on anecdotes or expert opinions or things like that. So this was a paper that we published a few years ago. So if there's questions that you want to look at, or if there's any specific references that you want to look at, you can look that up. It was published in the American College of Surgeons about 2 years ago, and I was the senior author. So I think I'll start. As you know, patients who have lymphedema, or patients who have had axial lymph node dissection, or even a sentinel lymph node biopsy, are given a laundry list of things that they should or should not do to prevent their lymphedema getting worse. So one of the things they're, for example, told is to avoid needle sticks, which I was just talking about. Avoid limb constriction, elevate the arm. Patients are told commonly to wear compressive garments when they fly, or when if they have lymphedema, to avoid flying altogether. One of the things that we tell patients all the time is to maintain a normal body weight, avoid extremes of temperature, avoid vigorous exercise. So these are some of the things that I'll touch into, and for each one, I'll try and sort of look at where the history of it was, where this sort of idea came from, what the evidence for it is, and then what the evidence for it against it is, and then a final verdict. And of course, you have to take some of this with a grain of salt, because some of this needs to be individualized. So this is just based on a literature review, and I think we'll start with that. So before talking about anything, when it comes to looking at the validity of a particular study or not, the best thing to do, or the simplest thing to do, is to look at level of scientific evidence. And when you look at levels of scientific evidence, you can think of that in 5 levels. Level 1 is the highest level of evidence that we have. It's the best way we can prove that something is true or false. And level 5 is the lowest level of evidence we have. Level 1 studies are randomized control studies, basically studies where you take patients and put them into 2 groups. One group of patients gets the treatment that is the experimental treatment, and then the second group of patients gets the standard treatment, and then you look at the results in a blinded manner, so no one knows what the treatment actually was. The next group of studies, the level 2 studies, these are also very good studies, but these are not randomized. The difference between these is that these are still done ahead of time. In other words, the patient groups are established before the project is started, so that we can look at the patients prospectively and follow them through the time. The next level of studies are the level 3 studies. These are well-designed observational studies. What that means is that we basically look back at a group of patients. We don't have a control group for these patients. So if there's a group of patients who had lymph node dissection, for example, there isn't a group of patients who had breast cancer who did not. But these are well designed, and they're followed through time. The next level is the level 4 studies, and these are really what's the most commonly performed studies in the medical literature. So if you were to read in medical literature about most diseases, most of the level of evidence that we have on a lot of things is level 4, and these are really retrospective studies. Someone treated 100 patients with lymphedema, then went back 2 years later to see what happened to them if X, Y, or Z happened. They're case series, so someone treated 100 patients in a particular way and wrote up about it in that way. So these are level 4 studies. And then finally, level 5 studies are expert opinions or committee recommendations, but these are not based on actual experiments or actual patients that are followed, but really what people think is the best treatment possible available. So let's go to the first topic, avoid needle sticks. The history of this is probably back to 1921, when Halsted came up with the idea that infections or things that caused inflammation in the arm or limb worsened or caused lymphedema. And really it stuck after that. And there is some evidence for it, and there's also a little bit of evidence against it. So when you look at the evidence for it, there was really just one single level 2 study that was done. It was a very, very small number of patients, 188 women, and this was a survey that was done. And what the report was that 44% of women who had developed lymphedema had a history of needle sticks, whereas 18% of them who did not develop lymphedema did not. And the conclusion was that needle sticks were a risk factor. The problem with this study, of course, is that they didn't really touch on the timing of it. So we didn't know if the needle stick were within the last week, last month, or 3 months before. And they didn't really control for the other risk factors. So, for instance, we know that weight gain or obesity or things like, or radiation is a risk factor, and they didn't control for that. So it's a good study in that it was done prospectively. It's not a good study in that it didn't sort of focus on that particular topic. A couple of small retrospective studies where they look back at patients. 79 patients were reviewed in one study, and they found that 3 of them developed lymphedema immediately after needle stick. Another study of 114 patients. And this study sort of didn't break it down to the needle sticks, but looked at infections after a bite or a scratch or any other thing that caused a break in the skin, and 53% of those patients had it. So there is some studies that suggest that. And there's a few case reports and scientific meeting reports and expert panels. Really, the evidence against it is that there was one retrospective study with about 350 patients in whom they only found 4 patients who developed lymphedema. There was another study that looked at 14 patients, none of whom developed lymphedema after what they called a non-accidental needle stick, which was basically an area that was sterilely prepped. And of course, there's lots of patients who have actually lymph node dissection or lymphedema who have hand surgery, and the reported incidence of lymphedema in those patients actually is very low. So the thought is that, so I guess to summarize this, I think this is probably true. I think needle sticks or things that may cause infections should be avoided if possible, but I think that it should be rational too. So if an area is sterilely prepped, or if there's no other options available, it is an option to do in someone who's had actually lymph node dissection without lymphedema. Certainly, I think it's probably not true in someone who's had sentinel lymph node biopsy and no lymphedema. But I think this is the area where it needs to be sort of individualized. Next topic: avoid lymph constriction. We had a hard time finding out where this idea came from, but there was a few reports that suggested that increased venous pressure in the arm or leg by several different investigators may cause the backflow of fluid from the veins into the interstitial space where the fluid is from lymphedema, and that may cause it. So that's the origin of this, where it came from. And really, there's no real good evidence for it, but there is some evidence against it. So I'll go through that. The evidence for it is just expert opinions. The studies that I mentioned, they didn't actually do any studies. They hypothesized that based on this mechanism that you may get worsened lymphedema. When you look at the against, there was a couple of fairly small studies. These were level 4 retrospective studies, and they basically applied a tourniquet to the patient's arm for 10 minutes and really found no effect. These were patients who had had lymph node dissection. And then there was some studies with patients who had actually lymph node dissection and hand surgery. In these cases, these patients have a compression that's applied for somewhere between 10 and 30 minutes, and they did not have any new cases of lymphedema. And finally, there was some surveys that were done asking hand surgeons if they think that actually lymph node dissection is a contraindication to compression, and 79 to 98% of them did not think so. Similarly, 68% of breast surgeons didn't think that it's a contraindication. And then there's also some expert opinions. Of course, you have to think about this, that we use compression routinely to treat lymphedema. So why would compression applied this way be bad for it? So the verdict on this is that it's probably fiction. I think if you have a very constricting band, it's probably not great for the circulation of the arm. So I think that should probably be avoided. But I think that regular clothing or things like that is probably not a problem. Well, what about elevating the limb? This is something that's told patients with lymphedema or actually lymph node dissection all the time. And the idea is probably related to avoiding blood pooling in the various areas, which makes sense when you think about it. But when you look at it from a scientific standpoint, there really is very little evidence for or against it. The evidence for it is just basically expert opinion, no actual studies. And the evidence against it, again, is just expert opinions, keeping the idea that keeping the limb elevated is good for edema, but not lymphedema. The difference being the amount of protein that's actually in the fluid. So this particular idea is probably unknown, but probably mostly fiction. This is something that's told to patients very commonly, both patients who have lymphedema and those who have axial lymph node dissection. In fact, some patients don't travel because of this concept, so they avoid traveling altogether because they're afraid that it's going to make their lymphedema worse. The history of it, difficult to find, but there were some studies from Australia and other surveys that suggested that patients who had worsened their lymphedema after flying or developed lymphedema if they had axial lymph node dissection. Well, what about when you look at the evidence? There is some for it and there's a little bit against it. The evidence for it is there was an anecdotal report from an Australian author that estimated the risk to being 5 to 30%, but they did not actually give the evidence for that or cite any patient data on that, but this was an expert opinion. There was a retrospective survey of about 531 patients who had symptoms of lymphedema start after flight. 27 out of 531 developed symptoms after the flight. When you look at the evidence against, it's a little bit stronger. There was a prospective study, level 2 study done that was looking at women who were flying from Canada to Australia for dragon boat races, and they found no changes in impedance. That's when you measure the amount of time that it takes the electricity to travel from one limb to the other, and that's a good way to look at fluid in the tissue. So they found no change in impedance in 95% of these patients without compression. And then there was another retrospective study looking at 293 cancer survivors, and they looked at precautions that these patients take. And in fact, no one developed lymphedema after flying. And one of the things that they thought was interesting is that the patients who actually took precautions were more likely to develop lymphedema. So these were 293 patients who did not take precautions. So the verdict on this is it's probably fiction, but I think it's something that probably needs to be studied more. This is a very common thing that's told to patients who've had lymph node dissection or any treatment for cancer. Maintain a normal body weight. And I think this is a good practice in general, but there's a lot of really very strong evidence for it, for lymphedema in particular. Of course, the history for this goes back to sort of the risk factors that are risk factors for lymphedema in general, and we know that obesity is a very significant risk factor. We even know that even if you gain weight after surgery, your risk of lymphedema goes up 8-fold. So we know that weight changes and dietary changes have significant effects on lymphatics. And there's a lot of evidence for this particular admonition. So if you look at this level 1 data. These are randomized clinical trials. There were, albeit this was a small study, but 21 patients comparing either a diet study or not. And they found that the patients who lost weight, who were randomized to the weight loss group, actually had much less volume in their arms, so the lymphedema got better. Level 2 studies, multiple studies have been done in level 2, 768 patients, 137 patients, 138 patients, 1,000 patients. All of these show that the risk of obesity is increased somewhere between 2- and 3-fold. Risk of lymphedema is increased somewhere between 2- and 3-fold with obesity. And then there was a study that showed that even mild weight gain, BMI of greater than 25, which is not obesity, it's just overweight, increased the risk of lymphedema. And then, of course, there's some retrospective studies. The best one was a study by Jean Petrick, who followed patients for 20 years, and she found again that obesity or weight gain was a significant risk factor. There really isn't any evidence against this that I could find. So the verdict for this is that it's true. Patients who've had an axial lymph node dissection should avoid gaining weight if at all possible. I actually think of obesity, of lymphedema, as regional obesity. I think that part of the process with chronic lymphedema is weight accumulation in the arm, and that weight is really adipose tissues. So I think there's sort of an increased risk for obesity in the particular limb. Avoid extremes of temperature, either cold or hot. The history for this, again, I couldn't really find a very good history for this, but there's a lot of areas where people are told to avoid extreme cold. They're told to avoid extreme exposure to heat, such as hot tubs. They're told to apply sunscreens. And the rationale for this is really the thought that maybe rebound circulation may increase blood flow to the limb, and again, similar to the avoid keeping the limb in a dependent position, increase lymphatic fluid load. So increase venous fluid in the arm or leg, increase blood, increase fluid in the arm, worsening lymphedema is the rationale. And there's some evidence for, but it looks to me like there's more evidence against. So the evidence for it, some case reports, level 4 data. There was a case report of a 50-year-old patient who had a 25% burn, and he developed lymphedema afterwards. A few other case reports of similar type burns who developed lymphedema. Level 5 studies of expert opinions, again, things that I mentioned before, based on no clinical data, just really expert opinions. The evidence against, there was one randomized controlled trial. One of the things you have to remember is that one of the sort of basic premises of lymphedema treatment in the Eastern literature is heat. Heat application is actually thought to help a lot with lymphedema in Asian cultures, and they proved this in a double-blind randomized study to show that heat therapy actually decreased lymphedema in this group. There was several prospective studies. One study with 98 patients showed that 85 of them had decreased in their limb volume with heat. Three-quarters of them had more than a 50% decrease. Another study with 1,000 patients showed again that was helpful for lower extremity lymphedema. And then also some case reports and expert opinions. So looks like the evidence for this is probably fiction. I think the preponderance of evidence supports that heat is probably helpful in lymphedema. I think people have to be careful about this. Many patients who have had surgery have changes in their sensation in the skin, the sensitivity of the skin, so it's possible for them to get burned, and I think that would be a bad thing. So extreme heat, which may cause a burn or is unmonitored, is probably not a good thing. But some heat, for example, in a hot tub or something like that, where the rest of the body is exposed, also is probably okay. What about this? Avoid vigorous exercise. For many, many years, patients who had an exit lymph node dissection or lymphedema had been told to avoid vigorous exercise. And again, the reason for this, or the rationale for this, was the concept of increased blood flow that I've told you many times before now. The thinking being that you have more blood flow because of exercise, more blood in the tissues, increased vascular load, and then increased edema from lymph fluid accumulating. But it really seems that this one is particularly wrong. The evidence for it was there really one study that showed that patients who did quote-unquote vigorous exercise were at increased risk of lymphedema after actually lymph node dissection. But again, this wasn't controlled for other risk factors or other issues. And then some expert opinions or level 5 data. But the evidence against it is level 1 data. Randomized control studies showing that patients who exercised or were in a monitored exercise programs were, number one, at a decreased risk for developing lymphedema, and those who had lymphedema actually improved with it. And this is probably related to weight loss. I think probably these patients exercised, increased their ability to metabolize, and lost a little bit of weight. So this is certainly fiction. Exercise does not increase the risk of lymphedema. It may actually improve it. The caveat being that I think that patients who've had surgery or lymphedema may need to be supervised in their exercise programs, and I think that's important. So in conclusion, what are the facts and what are the fiction? I think maintaining a normal body weight is definitely fact. I think avoiding weight gain after surgery or in patients with lymphedema is critically important. Unknown, I think needle sticks is probably unknown, and I think it depends on the circumstance. In the fiction, a lot of fiction in the lymphedema literature. Avoid exercise. I think you should do the opposite of that. Avoid air travel is probably not true. Avoid extremes of heats and cold. Certainly you don't want to burn yourself, but I think regular heat or cold is fine. Elevate the limb and avoid lymph constriction. But I think the take-home message for this is that additional research is necessary, And we need better and high-level studies to be able to study this. So I'm happy to answer any questions at this point. Oops, I went through them all this way. We can skip to the end.